welcome. It's nice to meet you. I've met many of you. So when I give these talks, I actually really appreciate if you'd interrupt me and either make a comment, disagree with me, agree with me, ask a question, share a patient story that you may have. But I think we can all identify with patients who have gastroparesis. We can understand that they are miserable a majority of the time. We are all here to try to help them. And what we lack is tools to help them. And so we're going to talk today about a lot of ideas about different tools we have, Enterra being one of them, but I like to think about this as a holistic approach to giving patient care. So as I said earlier, I practice up in Seattle, Washington. I've been a PA for 19 years, been using Enterra since about 2010, and I've had a lot of good experiences with it. And then over the years, I've been able to kind of try some different career growth opportunities. I've been the APP lead in our section, so I'll design our orientation program, our training program. I've also run our inpatient program before as well. And then in the more recent years, I've had the opportunity to do more leadership in the motility and functional GI space. So we've been running some programs there. So some of this we talked about last night, but we're just going to do an overview of gastroparesis first. Then we'll talk about the approach to diagnosis, the way we conceptualize treatment, and some of those tools and advanced options. So the stomach. I love the correlation to congestive heart failure. I like to think about, is our stomach expanding like it should? So when a person's first eating, they take 2 bites of food and they say they feel full, I think something's wrong with their gastric accommodation, the ability for the stomach to stretch and accept food. How angry do those nerves get? One of the things I remember is that water is one of the heaviest things to go in the stomach. So sometimes I'll ask them about just straight water. Because water doesn't have any caloric content, right? It's just water. And so if they're having trouble with water, it doesn't have to do with the fat content or the fiber content. It has to do with gastric accommodation. So I ask about drinking water sometimes. Then we think about the stomach accepting that food first. That's the accommodation. But then it has to kind of hold on to that food for a while. And how comfortable is it? So that's where that question about postprandial fullness, postprandial bloating, epigastric pain comes in. How comfortable is your stomach holding on to that food? And then how long do you feel full for? So how long does it take to push that food out of the stomach and you feel like you're ready for your next meal 3 or 4 or 5 hours later, or are you still feeling full from that meal you had at breakfast? So we talk about the stomach in a controlled emptying pattern. Well, a controlled emptying pattern means that the pylorus needs to relax open. So if we have pylorospasm, then it's going to really cause gastric retention. And then we need to think about the antrum. It needs to push food forward, but it has to do that in a coordinated manner with the pylorus. The pylorus needs to relax open, the antrum needs to be able to push forward, and then the duodenum, now it's turn to be an accommodating organ. It needs to accept that food from the stomach. So all of these things happen in a controlled and patterned manner. Symptoms of gastroparesis, the most common symptoms of gastroparesis we've already talked about. Fullness when you try to eat a meal, early satiety, but also postprandial fullness, bloating in the stomach. I ask patients, where do you feel bloated? Because if someone says, oh, my entire abdomen feels bloated, that's very different than someone saying, right here feels bloated. They'll say it's hard like a rock, or it feels like a brick is sitting in my stomach. That's that postprandial discomfort. And then, of course, nausea and often vomiting of food that they ate before. Now, what then goes along with that? Well, if you have delayed gastric emptying, then you're going to have more gastric regurgitation from the stomach, so you'll have more heartburn or regurgitation. You may have abnormalities in your blood sugar levels, especially if you're a diabetic. We'll talk more about that. You may not have an appetite to eat at all. And you may have either excessive weight loss, but who in their practice has seen gastroparesis that are obese, right? And that actually gain weight. And now, thankfully, this is not happening as often anymore, but I used to get insurance denials for Enterra because the insurance company would say, your patient's not sick enough, they haven't lost weight. We'll consider this if they've lost more than 10% of their body weight. And that would make me so angry Because these patients, they're eating carbohydrates, right? They're eating crackers, they're eating things that can easily dissolve in their stomach. That's a carbohydrate-rich diet. Are you gonna gain weight even if you're not eating much, if you're only eating sugars? So these patients can definitely have weight gain. Then let's talk about nausea and vomiting, because you know how a patient comes into the clinic and they say, oh, I have diarrhea, and you find out you don't have diarrhea. Your stool's not actually loose. You're going to the bathroom twice a day. That's not diarrhea, but they feel like it's diarrhea, right? So the same thing with nausea and vomiting. Sometimes that's actually regurgitation. Sometimes it's gastroesophageal reflux disease, and it's coming up to their mouth, so they say that that's vomiting, right? But let's talk about, well, what is nausea and what is vomiting? Nausea is a sensation. You feel nauseous. That is not a motor reflex. The motor reflex is vomiting. So when you vomit, you actually have, again, this coordinated set of events where the diaphragm pushes down. You have a retrograde contraction of the gastric antrum, so it sends it up. You have to relax open your esophageal sphincters. All of these things are happening at that miserable moment where you're retching. That is a motor reflux. It is induced by the neurologic event that feels like nausea. So nausea is a sensory perception, and it can be so severe that these patients can't get out of bed. It can be so severe that they don't feel like eating, that they can't do their job. So nausea is actually something that can come from the stomach, but it can also come from the brainstem. So you know, if you are exposed to a toxin, that toxin circulates through your blood system, and you might naturally throw up as a response to that toxin, but that toxin might get sensed by the brain stem nausea sensation center. So nausea can come from different places. And I really like to ask about, where are you feeling nauseous? Is your nausea from here? Is your nausea from here, or is it from here, or is it from here? I've had people tell me their nausea's down here. I'm like, oh, well, is that gastroparesis, or is that something else? I have a patient who was suffering from such severe anxiety that she was nauseated here every day. And she had all the tests under the sun that were all normal, because this was where her symptoms were coming from. So asking where they feel sick is an important thing to do. We think about all of these abnormal functions, but when you're in clinic with a patient and you're asking them about their symptoms, break it down. I like to think from head down. So I say, okay, do you have trouble swallowing? Are you having regurgitation? Are you having heartburn? Are you feeling full when you eat? Are you feeling nauseous after you eat? When you throw up, how many hours after eating? And was that food from several hours before? Or do you throw up immediately after eating? And both of those scenarios can happen with gastroparesis, but I think by definition, when someone tells me, oh, I threw up what I had for breakfast in the evening, then I'm really starting to think about gastroparesis. But these patients can have such severe symptoms that they're vomiting right away too. All right. So, nausea, what's it from? That's where this can get a little bit overwhelming. But just like we learned in school, nausea is a reaction to a medication. It could be a neurologic nausea. It could be a centralized nausea vomiting syndrome, like cyclical vomiting syndrome. There can be a link to migraines. We can see gastrointestinal motility disorders, both in the stomach and in the bowel. We can see gastric luminal lesions, H. pylori ulcerations, gastritis. These can all cause nausea. We can think about endocrine abnormalities. Parathyroid disease can cause nausea. Thyroid disease can cause nausea. Of course, there can be sort of a psychogenic nausea. So I had a patient the other day who has really severe anxiety disorder. She's having panic disorders, and as soon as she thinks about getting anxious, she immediately throws up. So it's super linked to anxiety. But just like we learned in school, the history is 90% of the answer. Before we do any testing, we have to ask questions. And so if you ask about the story, okay, well, what's going on? Walk me through this. Walk me through a day. You get up in the morning and what? Do you have an appetite? Are you nauseous from the moment you wake up? Oh, do you have to smoke some marijuana to even generate enough appetite to eat, right? So then you're like, oh, how long have you been smoking marijuana for? Oh, how often? Okay, what's going on with that, right? Why are you, so start to ask all these questions and really put the story together. Where is the nausea? What other symptoms are going along with it? Oh, this started after you started that medication. Let's talk about that. So really spending your time on history is important. And it's overwhelming to look at that list, but then as soon as you just start going down a pathway of questions, you get there, right? This is the magic of seeing patients in clinic. So in order to put the diagnosis of gastroparesis together, in order to decide, well, I think that gastroparesis might be why you're experiencing so many of these symptoms, we need to first of all kind of have that fit, that postprandial fullness, that early satiety, that vomiting of old food. Like, we need to see at least some of those components. But then we need to do an upper endoscopy, and specifically, we need to rule out gastric outlet obstruction. We need to rule out gastrointestinal lesions. H. pylori is notorious for making you feel sick as a dog. So make sure that there's no H. pylori or gastritis. And then we need to do that famous old delayed gastric emptying, and we'll talk a little bit about that today and some other diagnostic opportunities that we do have. But most importantly, I want to hit home with this because I think this day and age, raise your hand if you've seen someone sick from GLP-1 agonists. About 100% of the room, right? And we know that these are very effective at causing delayed gastric emptying, and in fact, that's one of the mechanisms that can help a patient feel satiety so that they're eating less and accomplishing their weight loss goals and their blood sugar controls, and it also helps with glucose metabolism. These drugs are extremely effective. They can work really, really well. I think that they're a net win for our medical institution because they're really helping people with some difficult weight loss scenarios. But they do cause delayed gastric emptying. So have you guys ever done a gastric emptying test inadvertently, because none of us would do it intentionally, but have you inadvertently found out that you have this delayed gastric emptying test and they were on one of these agents? Have you guys seen anyone yet do this? Yeah. So I had a patient come in who had really severe gastroparesis, and everyone was really worried about her. And her gastric emptying test showed that she had 78% retention. So almost 80% of her meal was still in her stomach at 4 hours. That is pretty rare to see that degree of gastric retention at the end of a gastric emptying study. Found out she was on Ozempic. Okay, let's stop that drug. We waited 6 weeks. Her symptoms went away. Her gastric emptying at 6 weeks was 4% at 4 hours. These drugs work. They are really good at causing delayed gastric emptying, so I was pretty impressed with that. Of course, opioids, we'll talk a little bit about that today, as well as the good old marijuana. So let's talk about the gastric emptying study, because you can really do this wrong. First of all, you could do the study on a GLP-1 agonist, and we talked about how that would be wrong. You could do this while someone has been using marijuana. We'll talk about marijuana, because marijuana is a little bit tricky. It's an interesting one. But what my gold standard is in our group is that you're off opioids. I prefer 72 hours off opioids. That's usually enough time off opioids to do a gastric emptying study. You're off marijuana for 6 to 12 months, but we'll talk a little bit more about what I mean by that. And then GLP-1 agonist, do you guys have any timeline? Do you think 4 weeks is fair to be off? Because some of these have a pretty long duration of action, right? Especially when they're dosed once a week. So I think that there's more to learn on this, and I think hopefully in the next 2 years we'll get more data on this, but I think 4 weeks is about what we're doing. And of course, at the end of 4 weeks, if someone's been off the drug and they feel fine, we might not even be doing the gastric emptying study. So follow up with them before you decide. And then importantly, blood sugar. On the day of the test, in the moment that you do the test, if your blood sugar is 350, you're actually going to have abnormal motility of the stomach in that moment. So it's important that day that you show that their blood sugar is under much better control. Is anyone using 2-hour studies at their institution? Good. I'm starting to see that those are going away. We really want to get that 4-hour data, but technically you could have 60% retention at 2 hours and be considered as a gastroparesis patient. But really we're looking at 10% of that meal is retained at 4 hours to have a positive gastric emptying study. But what's the problem with this? Is your gastric emptying the same every day? No. So you have a patient who you really believe has gastroparesis, and they have a good gastric emptying study. Well, what happened? They just had a good gastric emptying day. So you might have to repeat this test. And it's, in fact, only reproducible about 70% of the time. So if you have a patient who has a normal gastric emptying test and you really think they have gastroparesis, I think you're going to want to repeat it. But the other thing I do is I have them just bring a book to the test, because if they're walking around between the scans, they're going to empty their own stomach. And we can use that as a treatment tool. We can tell people that if you walk around after you eat a meal, that actually elicits gastric emptying. So we want them to kind of just be chill, relax, just sit there so we can kind of see what the native stomach motility is doing. The other thing we know is that you may have a patient who has really severe symptoms, but maybe their retention's like 12%, 14%. That's not that bad. It's kind of close to normal, right? There's not a good correlation between the intensity of someone's symptoms and their actual retention at 4 hours. So just really be focusing on, do they have a positive gastric emptying test or not? Yes or no. Do they have a negative endoscopy? Yes or no. And then really try to treat them to the degree to which they're feeling terrible. Try to treat their symptoms. I really appreciate this study. It is so validating to know that gastric emptying studies are not reproducible. So you can tell your patients, you know what? You can do the test this year, you can do it next year, and it could be normal, but you could still be feeling sick. So I caution you against repeating the gastric emptying test if they have an established diagnosis of gastroparesis and you just want to see if they're better now. Well, that's not really how it works. There's not a cure for gastroparesis. So once you've established the diagnosis, I'm not a huge fan of repeating the gastric emptying test just to repeat it. Because then guess what? Let's say you get a normal gastric emptying test. Is insurance going to cover advanced treatment options because they have a normal gastric emptying? No. So only repeat the test if it's clinically warranted. So if I get a patient who comes to see me and they were diagnosed with gastroparesis 12 years ago, and I want to see if they still have gastroparesis because they're so sick, I'm trying to figure out what's going on, I'm trying to figure out if they're a good candidate for Enterra or pyloric interventions, then I might repeat it to see. But if it's an established diagnosis, don't repeat the test unless you have to. So we talked a little bit about how imperfect the gastric emptying test is. So what else is there? Is there another way to think about gastroparesis? Well, if you ask the insurance company to approve a treatment for gastroparesis, they're going to want the gastric emptying test. But as a clinician, you're going to want the gastric emptying test because you want to understand some of the dynamics of the disease. But what else can we do? So in addition to the gastric emptying test, there's something called the water load test. We talked about how water can feel heavy in the stomach. Well, if you have a stomach that doesn't work right, that water load test is going to show a correlation between symptoms and possibly some delayed emptying. But liquid can go through the stomach just as fast as any other person who doesn't have gastroparesis. Liquid can kind of drain through even when the stomach doesn't work right, but they'll be pretty symptomatic. There is a breath test, the spirulina breath test, and for a while this was only used in research centers, but they're kind of coming back into the market again. They're starting to advertise because you could technically mail this to a patient's home. So this is really good for, rural medicine or a place where someone is unable to get a nuclear medicine scan. This is an option. There is a new technology out here we're talking about that is a high resolution electrogastrography unit. This has 64 sensors on it, and it actually measures the electrical activity of the stomach. It erases the electrical activity of the front abdominal wall muscles, And it is done in conjunction with a meal, so we're getting emptying information. It's also done in conjunction with symptoms over time. So pre-test, during test, and it's about 5.5 hours long that they're sitting there waiting for that meal to empty from their stomach, and we're checking to see what's happening in the stomach. Is the electrical activity abnormal? Is it normal, but they're symptomatic? Are their symptoms really high all the time? Whether or not they're eating, is it worse after the meal? So it can correlate that. They're also running the PHQ and the GAD scores during the test, so they can kind of measure the, psychological burden of each patient that comes through. And there are some interesting pattern correlations between their psychological survey questions and some of the presentations. So this is a sort of an emerging technology that we're looking at. You can also do anteroduodenal manometry, where you actually measure the motion of the antrum duodenum. This is really, really just in research centers. We've never done that at our institution. And then the functional luminal imaging probe, which, as many of you know, we use for achalasia, right? So this probe is designed to sit at the lower esophageal sphincter, measure the distensibility and relaxation of the lower esophageal sphincter, and that's one of our definitions of achalasia. Well, could we use that same probe down in the pylorus and measure the distensibility of the pylorus? And there's a lot of different opinions in the field on this. My personal opinion is that this was designed for the lower esophageal sphincter, which is a much smaller muscle than the pylorus. There are no validated norms for what the pylorus should be doing in terms of distensibility. So there's a high level of subjectivity related to the person who's interpreting this test. The catheter also can migrate, and you're not sure for sure that you're in the pylorus the entire time. So I think we have some interesting ideas about developing some technology to measure the pylorus, but I don't think we're there yet. It's not designed for the pylorus. So let's say you've made the diagnosis of gastroparesis, you've done your gastric emptying test, your endoscopy, they meet the symptom criteria, and they're not on medications that would cause the phenomenon. So what are the different causes? Well, if the patient has had diabetes as the cause, this is not a new diabetic. This is a diabetic who's been sick for years. And you'll see a high correlation between a diabetic who has neuropathy, retinopathy, nephropathy, because that's end organ damage from diabetes. The sugars have damaged the tiny nerves and the tiny blood vessels of our end organs. And so likewise in the stomach, we have nerve damage from the long-term complications of diabetes. And these patients have hyperglycemia more often. They could be brittle. They could have very highs and very low blood sugars. And the duration of their diabetes is usually at 10 years or longer. So I have patients who have post-viral gastroparesis, and then they just got diagnosed with type 2 diabetes last month. They don't have any complications of diabetes. I feel like that's an idiopathic diabetes or a gastroparesis patient. So post-surgical, is it any surgery? No. It's really a surgery in the upper abdomen, a cholecystectomy, a Nissen fundoplication, an esophageal surgery that can cause damage to the vagus nerve. I had a patient with 100% retention at 4 hours on her gastric emptying test. She had had a cardiac ablation that damaged the vagus nerve. Yeah, that is crazy. So anything that could damage the vagus nerve can cause gastroparesis. In terms of medications, there are many. We talked about this earlier, Pauline, is like dicyclamine, for example, that can cause slow gastric motility. Calcium channel blockers. We use tricyclic antidepressants all the time in our clinic. That can cause delayed gastric emptying and constipation, which can back it up. We'll focus today on these that are bolded because they have, I think, a special place in our world. Idiopathic, most of these are going to be post-viral. I definitely have patients who have like infiltrative disease, amyloidosis, sarcoidosis, I've seen that. Autoimmune disease. Think about scleroderma. You're dealing with probably much more than just gastroparesis. You're probably dealing with a lot of small intestinal, colonic, esophageal dysmotility. Mesenteric ischemia, I don't see that as a direct cause of gastroparesis per se, but something you don't want to miss because it might present in the same way. So sometimes thinking about mimicking syndromes. So let's spend a little bit of time on my favorite three: opioids, GLP-1s, and THC. So in terms of opioids, there is no good data on exact thresholds for us to use, which makes it difficult because these patients all present differently. But a good rule of thumb is if they're using opioids every single day, then it's part of the story. If they're using opioids a few times a month, then it's probably not part of the story. And then there's everything in between, right? And there is also some data on potency. So tramadol is a narcotic, but it's a very low potency narcotic. And of course, OxyContin is a very high potency, Dilaudid, very high potency. So depending on the amount they're using every day, you may or may not think that the opioid's playing a role. The overall dose could matter too. So I think there's a big difference between 5 milligrams a day and 90 milligrams a day of like oxycodone, for example. So unfortunately, we don't have any good guidelines to say this is the point at which the narcotic causes the stomach to slow, but I think you can use frequency of use, duration of use, and overall dosing to make that decision. Now, when we talk about Enterra, we're going to tell you that it's not indicated to use Enterra if someone is on opioids every single day chronically. And there is some data to suggest that even if you try Enterra, they're still going to do poorly because the opioid is driving the symptoms. And so until you can work with that patient in a collaborative partnership manner, this is not a place to lecture patients. They probably got to this place because of a well-intending provider who wanted to really help them with their pain, but that's where they are. And so if someone comes to me with a diagnosis of gastroparesis and they're on an opioid for 5 years every single day, and their dose has escalated over time, I'm going to remove the diagnosis of gastroparesis from their chart. And I'm going to say that they have chronic pain syndrome, daily use of therapeutic opioids. I'm going to say they have opioid-induced constipation, perhaps. I'm going to treat that. I might put on their chart that they have delayed gastric emptying, or I might put on their chart that they have chronic nausea and vomiting. But if they're on opioids, and even if they have a delayed gastric emptying study on opioids, that is not truly what gastroparesis means. That is an opioid complication. So I will remove that, I will educate them, and I will tell them, I will treat you for how you are feeling, but let's be clear about what might be causing this. So that's a very important conversation, and it's important to try to have it in a non-judgmental way with our patients, because they can get pretty defensive pretty quick, right? Don't take my narcotics away. So let's talk a little bit about marijuana. So you all know I'm from Seattle, and that is the marijuana capital of the world outside of Denver, Colorado. So do we see cannabis hyperemesis syndrome? Absolutely, we do. Well, what is that? What is the difference between using marijuana every single day versus using it 2 times a month? The difference is if this person has gastroparesis and they're using marijuana every single day for 2 years or more, I'm starting to think about cannabis hyperemesis. They're using it occasionally 2 or 3 times a month for relaxation or for fun. That's probably not CHS. CHS, in fact, looks just like CVS, cyclical vomiting syndrome. It looks just like it. They have a prodrome of building nausea. Oftentimes, people who smoke marijuana every day, they wake up sick. They have a morning sickness phenomenon. So I will ask them in clinic, you wake up in the morning, are you immediately nauseous? That's either acid reflux at night, really bad gastroparesis, or cannabis hyperemesis syndrome. They also can display this behavior of hot bathing, but it's not like a aha moment, you're lying, you're really using marijuana. cyclical vomiting syndrome can also do that, and what we realized is that there's a change in the endocannabinoid system, our system that regulates our temperature, that can be affected from chronic marijuana use, and that will lead to a hot bathing phenomenon as a way to cope with those symptoms. But you can see it in other neurologic syndromes as well. We do know that chronic everyday marijuana use will lead to delayed gastric emptying. We do know that this occurs with CBD and THC. And the synthetic cannabinoids, so like our dronabinol or marinol, all of these can and will cause delayed gastric emptying with chronic use. So that certainly can be the cause of gastroparesis. There can be a break between symptoms, but when they get sick, they have heavy vomiting. So think about vomiting for hours, refractory vomiting. They're going to the emergency room 3, 4, 5 times a month because they can't stay hydrated at home and they're so sick. The other thing about this is that it can take, and this is the hard selling point, 6 to 12 months of cessation to really get better. So we're all human beings. Our brains don't work like that, right? If I stop something for 2 weeks, I should be better at 2 weeks. So there can be a lot of, education around this in clinic where you're really going to have to get buy-in from your patients to go off of this for a long period of time and say, hey, look, I am going to help you with your symptoms while you're coming off of this, but we're going to need to get off of this. The other thing I tell them is that don't try to go cold turkey. Let's just have you start by using a little less, a little less, a little less over time. And importantly, why are you using marijuana all the time? What do you think the most common cause of chronic marijuana use is? Common reason. What? Stress, anxiety. Yeah, and then it just builds over time. You realize that, oh God, yeah, that made me feel better. Oh my pain felt better, I had a good sleep. I'm gonna start doing that all the time because it's natural, right? It's not a drug. Well, it is. That's something to spend a lot of time on, and this is an area where this is not instant gratification. You're going to be working with this person for probably a year, and you may find at the end of that year that their nausea vomiting is better. So that may solve it before you need to carry on with gastroparesis. And we talked a lot about GLP-1. We know that they're here to stay, and we think that holding them for 4 weeks is good to go. And then I chose these 3 as mimickers. So functional gastroparesis, that's kind of on the same, functional dyspepsia is kind of on the same continuum as gastroparesis. So it's going to present in the same way. It'll have the same cardinal symptoms. But in our minds, we're thinking this is the more pain-forward presentation. This is the patient who has pain every single day and then some nausea, or the pain causes nausea. They may have vomiting, but they're really having pain. This is your visceral hypersensitivity patient. They may have an overlay of IBS. So they're going to have, this is the Rome 4 criteria for functional dyspepsia. They're going to have postprandial fullness, early satiety, bloating pain. They may have nausea, vomiting, but they don't have to. Again, just like with gastroparesis, there'll be a lack of luminal disease, and their symptoms will be chronic. And so trying to understand where a patient falls in that continuum can be difficult because patients who have gastroparesis very much have pain as well and bloating and fullness. So trying to understand, well, what's the most predominant symptom is what we need to do. In terms of cyclical vomiting, they're going to have a migraine history or they're going to have a family history of migraines. They're going to be completely symptom-free between episodes, and there will be weeks to months between episodes. Vomiting is heavy, refractory, and if you get to it too late, just like with a migraine, if you get to it too late, if you don't catch it in the prodrome phase, you're going to be so sick you'll need to be in the ER for abortive medication. For these patients, I really try to put together a kit. This is the kit you use when you start to get sick, and I might even need to put together a preventative medication plan so that we can prevent these attacks from happening. It'll look a little bit like cannabis hyperemesis, and the only way to tell the difference between cannabis use and cyclical vomiting in this presentation is to stop the cannabis. That's the only way to tell the difference between the two. Of course, if it's cyclical vomiting, they won't get better. They often will have rapid gastric emptying. So that's an important thing to see. Have you guys ever done a gastric emptying test and been surprised to see that it's rapid? That they have 3% left at 2 hours, and so they don't even do the 4-hour test because their stomach is empty. So a lot of times patients with this more functional or neurologic presentation will have a rapid gastric emptying. And then let's talk a little bit about disordered eating and eating disorders. This is one of the areas that's really tricky to navigate. It's tricky to navigate when you're sitting in the room with a patient and you're wondering, okay, well, if you have been sick when you're eating for 5 years now, would you want to eat? Would you get excited about eating? Would you have fear when you think about eating, especially eating out with friends or at a holiday? Of course you would. So then does it make sense that this phenomenon that we now call ARFID, avoidant restrictive food intake disorder, would occur in this patient population at a high rate? Yeah. So when we think about that, we learn that, okay, we're going to start to make this person feel better. We're going to maybe give them some antiemetics. We may put a gastric neurostimulator in. We may have success with that. But have they just readopted normal eating habits? Or do they continue to display abnormal eating habits? And I think most of the time they continue to display abnormal eating habits and behaviors. I have had a patient recently who I placed in Enterra, and she was a rapid, early responder to Enterra. She's feeling better, and she just told me the other day, my grandma told me I look so good now that I'm this skinny. I don't really want to gain any weight. And her BMI is 17. And I was like, ooh, okay. We're going to talk to some therapists. So just being aware that these patients will have a negative connotation to eating is really important, and recognizing then what does that support look like. Now you can take the flip side. So let's take someone who has severe anorexia nervosa, or someone who has abused laxatives as part of their eating disorder. That's a psychiatric disorder, right? So will they present with gastroparesis? Yeah. They can sometimes have delayed gastric emptying. They can have abnormal motility. They can have colonic inertia from this history. But just bear in mind that that's very uncommon. That's your less common presentation. We're gonna see that. Please have a radar for that, but that's the less common presentation. It's much more common to have a gastrointestinal disorder and develop some concerns around eating. And we have wonderful dietitians who can help. And that's what I say. The words I use with the patient is, we need to rehabilitate your stomach. We need to normalize the idea of eating again. Your stomach has not liked it for many years, so let's ease into it. Let's do it with a dietitian. Sometimes we'll need to get a therapist involved as well. So I made this diagram because this is the way I conceptualize this. These symptoms of gastroparesis, nausea, vomiting, these are common symptoms, right? But they could present in all of these different ways. So I feel like gastroparesis and functional dyspepsia are pretty close friends. You can have similar test results with both of these conditions. But if someone has mostly pain and visceral hypersensitivity, going to be sort of leaning towards functional dyspepsia, and vice versa with gastroparesis. And similarly, cyclical vomiting syndrome and cannabis hyperemesis, they are very similar, with the only difference being that either that migraine history or that marijuana history, or the really fun one where they're taking marijuana to help with their migraines. Who knows? But if marijuana is involved, you're going to need to stop it to know for sure. All right. Okay. So now we've made that diagnosis, and how do we approach treatment? Well, I think the good news, so I started talking about gastroparesis at medical events in about, I think 2018 was the first time I gave a talk. And back then, we had nothing. We had guidelines that were last published in 2010, 2013. We just didn't really have much excitement in the field. It's a dead topic. These patients were stigmatized and kind of just, left to fend with it on their own. It was a frustrating disorder to deal with. But what's really cool right now, in the time that we're in, is that actually we're talking about it again. We've got guideline updates from the ACGA and AGA within the last 3 to 4 years. So here's AGAs, and I like this concept, the way they think about it. So you've got somebody, now this particular article is specifically about refractory gastroparesis. So you've got some gastroparesis patients where they get better on the diet and some antiemetics and they're fine, but what about the patients who continue to be sick despite these dietary and medication interventions? So for refractory gastroparesis, are they presenting with more pain or are they presenting with more nausea vomiting? And if they have nausea vomiting forward symptoms, what are we doing? So they talk about dividing this algorithm into nausea vomiting presentation, abdominal presentation. They also have a caveat here that you've considered mimicking diagnoses like we just talked about today, as well as sort of comorbid conditions that may be affecting their symptoms. This is the algorithm that we made at our institution, and it follows that same pattern. We're talking about making a correct diagnosis, avoiding things and adding things in that would be supportive. I'll talk more about this. And is it a nausea vomiting presentation or pain functional dyspepsia presentation? So we've talked about doing a high quality gastric emptying test, and I actually like to think about it as optimized. We've optimized our gastric emptying test. That means that they don't have hyperglycemia the morning of the test. We've avoided any medications that could slow or speed up gastric emptying. I didn't mention that, but of course, you don't want someone to be on Reglan during their gastric emptying test because that could speed it up and normalize it. So you've made that appropriate diagnosis, you've ruled out mimicking disorders, and we've avoided these medications that can contribute to the disease state. We've considered mimicking diagnoses, and we've also talked about management of comorbid conditions. So managing glucose. If your blood glucose is over 300, you're going to have delayed gastric emptying, you're going to feel sick. We've managed their SIBO, we've managed their constipation, we've managed their GERD. All of these comorbid conditions need to be considered when we're approaching this in a holistic way. And every single patient sees a dietitian. So dietitians can have their own private practice. And you want to sort of vet these people, though, try to get to know them a little bit, make sure that they have some experience with managing sort of the complexity between diabetes, especially in gastroparesis. But I think telehealth is a good way to go, yeah. And you yourself can become good at this, but how many different things do you have to address in that visit? Because you're also thinking about their constipation, right? And all these other things. So if you were to try to tackle this on your own, you could, and we can get really good at it, but you would need to maybe dedicate an entire visit to that, because it's actually quite complex. The other thing I tell people about the dietitian visit, have you ever had a patient say, oh, I don't need someone to tell me what to eat. I know what to eat. I'm already eating nothing anyway, who cares? They're gonna tell me to eat stuff I can't eat. Well, actually, what I want to do with the dietitian is I want you to go see them and sit down with them. I want you to bring in a 2-week diet journal. And I actually want the dietitian to do a nutrition assessment. So where are you in your nutrition? Are you in a malnourished state? Are you in a risk for malnourishment state? Or are you in a nourished state? Which vitamins might you be deficient in? So one of the things I love that my dietitians have started doing is that they'll send me a note in the EMR and they'll say, hey, I saw so-and-so today. They're really high risk for malnourishment. We're gonna try this diet, but in the meantime, can you check these 7 vitamin levels? Can you check their iron, their ferritin, their B12, their folate? And so then you can then give a nutrition assessment. So that's a good way to kind of word it to your patients so that you can get some buy-in. Because then once they meet this dietitian, they're gonna recognize how important this additional healthcare provider is in their team. So for patients who have gastroparesis and we've sent them to the dietitian and they're on a gastroparesis diet, but they're still feeling sick, then we start talking about, well, what do you do? So we combine prokinetics and antiemetics. Sometimes that does the trick. But we're also dealing with side effects to the antiemetic drugs. And sometimes they're not effective. And sometimes they can't afford the medications, right? Like this one here, this aprepitant, super expensive. And insurance does not want to cover it because it's only approved for chemotherapy. So then we have the option of going on to advanced therapies like gastric neurostimulator, pyloric interventions, which we'll talk about today. And for patients who present with that functional dyspepsia overlay, and they can present with both, right? We'll try things like neuromodulators with the caveat that many neuromodulators have anticholinergic activity and can make symptoms worse potentially. But low-dose tricyclic antidepressants could help with that pain that they have. We may try antispasmodics. Again, those will have some anticholinergic activity, so we have to be mindful of that. But hypnotherapy is an option, as is pain psychology. And pain psychology is another thing that I think we can start to access online. So I encourage you to research that in your area and see if you have some resources for pain psychology and pain coping skills classes. So when someone is acutely hyperglycemic, they will have reduced gastric antral contractility. They will have pylorospasm. It will actually inhibit the prokinetic medications that you're attempting to use. And it's important to recognize that some of the more recent studies that show patients who have the continuous glucose monitoring system and an insulin pump can have dramatic improvement in their gastroparesis. So for your diabetic gastroparesis patient, it's important to then say, well, we're gastroenterology providers. Are we managing diabetes? Nope. So we need to probably connect with primary care and connect with our endocrine services and make sure that we have a good partnership there. So we'll talk about diet next. So we need to limit fat. So in each meal, if someone is severely gastroparetic, I will ask them to limit their fat to like 10 grams per meal or less, because increased fat will cause delayed gastric emptying. And the type of fat matters. So in a malnourished person, if they're really low weight and we need to try to help them gain weight, but they have gastroparesis, I might try to use fats that are liquid. So a milkshake, for example, might be tolerated, but a hamburger absolutely would not be. So the type of fat matters. We'll modify fiber, and what I like about what's the kind of the conversation we're having these days is fiber itself is not the problem. It's the presentation of the fiber. So raw, stringy skins, like think about a bell pepper, think about celery. You can't break that down. That's going to stay in the stomach. But if we can peel it, cook it, mash it with a fork, then we can have a sweet potato, for example, that we've pureed and thinned down. Absolutely, you can have that. You can have squash. A lot of times if you cook the squash, you can even have the skin of the squash. I tell the patient, we're going to try to get your symptoms under control, and then your stomach's going to tell us what amount of fiber you can have. You can have a fiber supplement. That's liquid, right? If you mix it with a powder, or a powder with water, you can have a fiber supplement. So these people come into this and they think they can't have any fiber. You can, but you need to modify and soften the fiber. You need to peel and cook, mash, and create liquids. And then they can't have very much volume at any one given time, so we try to get them to eat at least 4 to 6 times a day, and even that can be hard. But making sure, and this is where your dietitian comes in, making sure that they're getting enough calories every day. And then we have some balance. We have some ways to get some protein in, for example. That's a hard one for some patients. Okay, let's talk about medications. I'm going to break this into antiemetics, prokinetics, and neuromodulation. And just a good reminder that if you go and you research gastroparesis with the FDA, you'll find that there is only one agent that's FDA approved. You know, we all use Zofran in our practices. It's not FDA approved for gastroparesis. It's only FDA approved for chronic nausea vomiting or associated with chemotherapy. And there is some, we're starting to see some approval for like cyclical vomiting syndrome in some of these drugs, so I'll highlight that with some of these. But one of the ones I use most frequently is ondansetron. Would you say that's your most frequent go-to antiemetic in your practice? And of course, we know that with ongoing use, you can get constipated. That's dose dependent. And then the headaches that people get from ondansetron is really just drug dependent, meaning that you're either going to get headaches or you're not. Whenever you take the drug, you're going to get a headache or you're not. So usually if someone gets headaches from ondansetron, it's probably not a good drug to use. If they get constipated using ondansetron, I'll try to manage that. I'll try to manage that by saying, well, let's use the lowest effective dose. Let's use a different antiemetic so we can kind of alternate it, because that's a dose dependency. The more ondansetron you use, the more constipated you'll get. And you can, start to play around with combining it with Miralax and some other options for treating the constipation. Prochlorperazine, promethazine works pretty well. I find it works really well in my neurologic nausea vomiting population, like cyclical vomiting syndrome. It can be in a good abortive medication. And some of these, you can get in like a suppository form or a liquid form, which you can play around with if they're throwing up pills. But the biggest side effect to this group is sleepiness. So sometimes the best I can get out of it is if you're sick in the evening, take it and go to bed. Or if you're so sick that you want to go to sleep, take it and take a nap. Other people don't really have that sleepiness side effect, so you can get away with it. In the antihistamine, antimuscarinic group, we can use things like scopolamine patches that are good for 3 days at a time. If well tolerated, this can be a pretty effective antiemetic. Benadryl can work, but just like with the promethazine, it can make you really, really sleepy, so that's something that will limit its use. Meclizine is another motion sickness drug that can work. Neurokinin 1 agonist, like aprepitant, this is one of the ones that does now have an FDA indication for pediatric cyclical vomiting syndrome. It works very well. It is very hard to get it approved. I do have a good appeal letter. If anyone wants it, let me know. I'd be happy to send it your way. But there is actually some data on gastroparesis patients, especially female and diabetic, who respond pretty well to aprepitant. It's oral and it's IV. And I've used it in both ways. I can use it as an abortive medication where I use a kit. It's like 125 milligrams and then 80, kind of get them through a really bad flare. Or can use 80 milligrams as needed or every day. That one I have a really hard time getting approved by insurance. They might give me 7 capsules for an entire month, so they won't give me 30, but 7's better than 0 if it works really well. And then for someone who's already on IV hydration, for example, I will use 125 milligrams twice a week IV. And that can really, really help reduce nausea. It's pretty well tolerated too. I haven't seen a bunch of side effects from it. Let's think about from an inpatient perspective or an emergency room perspective, if they're admitted and they're having super severe, refractory vomiting, intractable vomiting, they cannot stop throwing up. How can we abort it in the moment? ER providers will use benzodiazepines. I'll sometimes use those for the first 24 to 48 hours of the hospitalization, during which time I'm doing aggressive IV fluid rehydration, and that can sometimes get things under control. I don't like to use them as an outpatient because, of course, they're habit forming and they could be dangerous in terms of sleepiness, in terms of driving, so I don't use these on a regular basis in the outpatient setting. Haloperidol can work also. We see that used in the emergency room. Technically, you could use this as an outpatient, but pretty rarely, and you probably want to do it with a psychiatrist partner on board. When someone has been so sick that they're in the ER and they're admitted to the hospital, one of the things they need the most is just IV rehydration. Sometimes they get so dehydrated that that actually becomes the driver of their symptoms. So let's move on to the category prokinetics. So as Dr. Koch was mentioning last night, this is, this makes sense, right? If the stomach isn't empty, let's make it empty. Everything will be better. But it doesn't turn out to be the case. These actually are just sort of a big old disappointment. So Reglan, that can work. It can work in some patients. Some patients can feel like it's well tolerated. Some patients can feel like it works pretty well. It doesn't tend to work long term. And there really are some significant side effect burden here. Now, recently in the field, we've been talking about how tardive dyskinesia probably isn't as common as we used to think it was. So we don't have to scare our patients in the clinic with a big black box warning. But what do you do with that in actual real life? Well, we shouldn't be as worried as we used to be, but should we be a little bit worried? Well, how worried should we be? Well, how's your patient going to feel about that? So you still have to tell them that the extrapyramidal side effects are very common. You know, you can feel agitated, you can feel shaky, you can feel jittery, you can have insomnia, you can have hypersomnolence, your mood can change. Those are common. Those symptoms tend to go away when you stop the drug. But it's the tardive dyskinesia that's the one that's pretty scary, and that could be an involuntary muscle movement despite stopping the drug, and could go on long term. Now, they do have a treatment for tardive dyskinesia that we didn't used to have, but in general, I would say it's not my favorite drug for those reasons. I have had some patients who say they tolerate it and it works well for them. If that's the case and we need a temporizing measure, I might use it for several weeks. I might try to take some breaks here and there if I can, but it's not my favorite drug for those reasons. Do you guys all use domperidone? Anybody? A few? And how do you get it? Canada, and you're writing the prescription. And then are any of your patients getting their drugs seized at the border?
I've had it happen, yeah.
You've had it happen. Did you get a letter?
Did not.
Okay. Did the patient get a letter?
I think so.
So a big, scary letter that's actually several pages long that's like, this is against US law, this is a federal regulation that you're not allowed to take this drug, it's not FDA approved. They get a pretty scary letter. And so what happened at my institution is that scary letter started happening around 2016. We got a whole flood of scary letters. And, we're right next to Canada, so we use domperidone. We've been using domperidone for 40 years in our practice. We've never had an adverse reaction to domperidone in our practice. It is a safe drug, in our opinion. But they started getting these scary letters. Then our legal team found out about it, and our legal team said, nope, you're not allowed to write domperidone anymore. So here we are, Tertiary Center for Gastroparesis in the Pacific Northwest, and we're not allowed to write for domperidone. So it's a bummer. Some of our patients found out about a pharmacy in New Zealand. New Zealand. You don't have to have a prescription from this pharmacy. You can order it directly online. If you travel to Europe, you can get it from Europe without a prescription and bring it home. So there's workarounds. Now, if you do use domperidone in your practice, I get a baseline EKG. I check their med list to see if they're on other drugs that can prolong their QT interval. Tricyclic antidepressants is one of them. Antipsychotics are often one of them. Ondansetron, erythromycin are other examples of medications that can prolong the QT interval. So check their med list, check an EKG. For women, you want their QTC to be under 475 milliseconds, and for men, 450. Then they take domperidone, maybe they get it directly over the internet. Well, you want to have an open conversation about that, because if they are taking it, even if you're not prescribing it, you want to check an EKG sometimes 3 months later if they're borderline, 6 months later. I check an EKG every 6 months on these patients. It's also important to recognize that if you have severe hypokalemia, if your potassium is low, and that can happen from vomiting, right? You can drop your potassium down. You don't want to use any agent that can prolong the QT interval if they have hypokalemia. So make sure they're aware. And when they're vomiting really bad, they probably need to get treatment, check their potassium, get rehydrated, repleted, and then it would be okay to restart the medication at that point in time. What else can happen with domperidone? Definitely can get headaches, gynecomastia, lactation. This can happen to men. You usually need to have a high enough prolactin level that then the domperidone raises that prolactin level a little bit more, and that tips you over the edge with these other types of side effects. So erythromycin, anyone use that in their practice? No. What? Can't afford it. Yeah, it is expensive. Why? I don't know why it's expensive. It's been around forever. It shouldn't be expensive. But yeah, it can be expensive. And the other thing is it can cause nausea vomiting. So if I use it because I need something right now. And I don't have another option, let's say. And I want to see if it works, because I'm curious to know if it works. But it does increase the migrating motor complex. The problem is that your body quickly becomes tachyphylactic to it, so it really only works for a couple weeks. I've had patients come to see me from outside institutions where they say they've been on erythromycin for 3 years without a break. I'm like, well, it's not working anymore. So if I do use it, I'll use it for 2 weeks at a time. I'll take a break, and I'll say, well, you can use it again. This might work for your patient who has like flares of nausea, vomiting, and then they might go and their symptoms are a little bit less intense, or maybe they got a virus and things got worse for a while. This can work. I also use the pediatric liquid erythromycin because I can take half the dose that way. Otherwise, you can't split the dose. If you get the 250 milligram tabs, that's as low as you can go. But I like to use 100 milligrams 3 times a day. So I'll take the 200 milligrams per 5 milliliters, and I'll have them take 2.5 milliliters of that, so half the dose 3 times a day. Still a little bit of a pain because the pharmacist has to mix it for them, and they might have to go back for a second bottle during the course, but you can kind of make it work. So it's a bit of a hack, right? But it can help. And then medications that are enterokinetic. So we were all really excited about prucalopride when it came out a few years ago, because we thought, oh my gosh, this is going to be our new gastroparesis drug. It's related to cisapride. It's going to work. We think it's going to work. It's safe. It does work really well for constipation. And we talked about how patients who have gastroparesis have constipation. So this is a really good option for your patient who has constipation. A lot of people will use it for gastroparesis, and they've had some success with it. But I would say maybe mediocre, in my opinion, in terms of gastroparesis itself. But if they do have constipation, you need to treat that, or their gastroparesis won't get better. So this can be an effective tool. I do use pyridostigmide on occasion, not very often, but this is really more for my whole gut dysmotility group. This helps sometimes if someone has coexisting EDS and POTS to help manage their whole gut dysmotility. I don't find it to be effective as a gastroparesis-specific medication. So for our patients who present with pain, we talked about this a little bit. So nortriptyline was formally studied in the gastroparesis population. It was not found to be effective. It was not found to be more effective than the placebo group. Now, amitriptyline does have favorable studies in the functional dyspepsia space. So I think you can still really reliably use these. I do start at pretty low dose. I personally start at 10 milligrams of one of those. I monitor for constipation side effects. I monitor for hypersomnolence side effects. And those sometimes will limit my ability to raise the drug to an effective level. We might have to discontinue it. We also can play around with things like other types of antidepressants and anxiolytics. So mirtazapine is an antidepressant. It stimulates appetite. It can to some degree help with nausea. Side effect is weight gain. So really remember that. That actually might be something you want if you have someone who is severely cachectic and has lost weight. You may want to try mirtazapine, but for someone who is at baseline obese, you may want to avoid mirtazapine for that reason. Buspirone kind of had a reputation on the street for a while of being this great drug for gastric accommodation. No, it doesn't really work that well. But I have tried it for someone who has a strong underlying anxiety disorder and they need an adjunct therapy. Might help their stomach, but I think the reviews are pretty mixed. And then you start getting spicy with things like olanzapine, and this does like 8 different things in our neurologic system. I have only used it a couple times. Has anyone in here used olanzapine? You've used it? Did you have a psychiatrist involved in the sitch? No? Really like 2.5 milligrams. Did you have some success with it? Weight gain? Yeah, that definitely is a side effect that's concerning. I think when you start to get into the olanzapine space, I personally prefer to have at least a primary care kind of conversation or a psychiatrist conversation about using it. It does work on many different receptors. I've actually only really used it in a couple of refractory cyclical vomiting cases. I haven't used it in gastroparesis per se. It doesn't help with gastric emptying. And then certainly it's very reasonable for us to try our herbal options out there. Our IB Guard can help with bowel spasm. FD Guard can help with gastric distress. ginger can help reduce nausea. And there are some patients who really want to try as much natural as possible, so you can give them some ginger, some B6, some IV Guard, some FD Guard. Okay, so now we're in that space of refractory gastroparesis. So the gastric neurostimulator, that's what we're kind of here to talk about today. This is a device that is implanted. The actual device itself is subcutaneous under the abdominal wall. It's usually on the left or the right side. If someone's really thin, they might feel it or even see it. But for the most part, it's deep enough that you have to really press to feel it. And then there's these two leads that go from the stimulator case to the anterior abdominal wall. And we'll learn later about how this is surgically implanted. But the component includes this system here, but then also this external stimulator device that we'll talk about. Over the years since Enterra has been around, there have been many studies trying to understand how it works. Which patients does it work in? How well does it work? Is it safe? But inherent to the problem of gastroparesis is numbers and power. So because gastroparesis is a bit less common in our space, it's hard to study it. It's hard to get good power behind our studies. Therefore, it's hard to analyze what works and doesn't work. And this is one of the reasons why we don't have a lot of good education about gastroparesis, because it's hard to study. This is one of the original studies, kind of the 2010, we call these the US controlled trials. We had diabetic and idiopathic patients. The device was implanted. It was on for 6 weeks. So we're going to see what happened at 6 weeks. Every single patient had the device on. And then it was turned off with half of the group, kept on in half of the group, and then they flipped it. They turned it back on. And then at the end of the study, everybody had it on for 4.5 months. So there's actually some study design issues that became apparent with this. And this might be why some people in the community weren't sure about the effectiveness of the device, and we'll talk about that. So at first look, you see that both diabetic and idiopathic patients got better, right? And if you look at 1 year, both patient groups got better, and this is clinically significant. But within the data set, there's some confusing things. So first of all, if you go from the diabetic group, they got better on that 6 weeks on. Then they continued to get better. When we turned the device off, they got a little worse, but not a lot worse. Well, what does that mean? And we think maybe there's some washout. Maybe after you turn the neurostimulator off, there's still some continued benefit. So it's not like a light switch. It's not like you turn it off. So like if you've ever had a patient whose battery died, it could have died a month or two before, but they just started getting sick. So there's a little bit of a carryover effect of the neurostimulator. So this is a little bit hard to interpret, but I think what's important to recognize is that it works in diabetics and idiopathic presentations, and it is a very significant benefit in a majority of those patients. So their total symptom score, this is the nausea, the vomiting, but also the bloating, the pain, the fullness. These patients both showed clinically significant improvement in their symptoms of total symptom scores. And 4-hour gastric emptying did improve, but that is not one of the clinical endpoints we're looking for. This is not, you know how you've heard of this called in the field, you've heard it called a pacemaker. It's not a pacemaker. It doesn't pace the stomach. It reduces nausea and vomiting sensations. Mean hospitalization improved dramatically, and I think the group that we really see this with is that diabetic gastroparesis group, because this is the group where they're suffering complications like DKA associated with their gastroparesis. And so we're really starting to see some stabilization in their blood glucose levels because they're hydrated, they're nourished, their DKA episodes are going down. We don't see as many admissions with idiopathic gastroparesis patients, so that hospital data is a little bit different to interpret. This is a study from France looking at 10 years of gastroparesis treatment with the gastric neurostimulator. In this group, we had 50, so again, kind of a lower treatment group, but this is pretty common for the gastroparesis studies. And what are the long-term safety findings for this, and what are the long-term efficacy outcomes? So when this study was done, they were really looking at quality of life over a 10-year period. And at 10 years, these patients had a clinically significant improvement in their quality of life. And when asked to rate their improvement, they were given a visual scale from 0 to 100, with 100 being, I'm fully improved, I'm 100% better. At 10 years, we had 80% improvement ratings. That is really, really strong for a treatment at 10 years. That is a good duration. And we did see that the two symptoms that improved the most was nausea and vomiting over that period of time. And importantly, we saw a sustained improvement in nausea and vomiting. So let's transition over to other types of care. So do you guys use Botox in your practices? Yeah? So Botox is a bit controversial. I think there's more to learn. For example, some institutions use 200 units of Botox. Some doctors feel that they have to push really hard into this spot or that spot, and then they're going to get it. But unfortunately, in the clinical trials, they found that the placebo group did just as well as the Botox group. Interesting, though, in other trials, they found that people who did have a benefit from Botox the first time around had benefit again. So you can use that as a guideline for yourself in practice. It's totally reasonable to try. The AGA says Botox is meant for clinical trials only. That is their position. But it's relatively low risk. Many practices are happy to do it. So it's fine to try. It's fairly safe. It's reasonable to try if the patient is wanting to do that. Pyloroplasty has been around forever. Surgical pyloroplasty has been around for a long time, and it was studied more in like the 1990s and the early 2000s, and it really just fell out of favor because it didn't offer long-term relief. And I feel like this is where we can start to think about the concept between neuromodulation versus something that helps empty the stomach. So if you take the tension out of the pylorus, then the stomach essentially drains better. So shouldn't their symptoms get better? If gastroparesis was only about gastric retention, then our patients should be better when we do pyloroplasty. But they're not. And I think that's when we start to recognize that this is a neuromotility disorder. There's a disorder with the nervous system of the stomach, and that's why people are feeling so sick. So with a surgical pyloroplasty, they're actually making a longitudinal incision and then they're closing it crosswise, and that is sort of propping open the pyloric sphincter. As surgeries go, it's pretty safe. You can experience a leak or an infection at the site. You could have a bleed. It does initially improve nausea vomiting in studies, but it doesn't necessarily have like a long-term sustained relief. The other problem with pyloroplasty is that we don't actually have good sham-controlled studies to be able to study this in a prospective manner. And of course, now the conversation about pyloroplasty is just blown up because we have the ability to do a pyloromyotomy endoscopically. So safer outpatient procedure. We can do this in the endoscopy suite. Our therapeutic endoscopists are happy to do it, right? Do you guys have GPOM available at your institution? Just by a show of hands. So some no. So no pyloroplasty, no GPOM. You do? So my therapeutic gastroenterologist is happy to do it, but it's still pretty new. So we're still within the first several years of looking at GPOM data. There are so many studies being published on GPOM. And I've seen studies say that they are 78% effective in reducing nausea vomiting. I've seen studies saying that they're 50% successful in improving nausea vomiting. I've also seen studies that have shown that maybe the improvement that we see within that first year starts to diminish over time. So it's fair to say that we have more to learn about GPOM. We have more to learn about when to use it, why to use it, how to use it. Should we do it with Enterra, separate from Enterra, first or second? I think that's where we're all across the board right there, and I think we have more to talk about. So some of the initial studies, however, do show that there is some improvement in symptoms. Nausea vomiting symptoms can improve. We have seen that the gastric emptying study can improve dramatically, but just like with testing the gastric emptying test, we don't always see a good correlation with improvement in gastric emptying and symptom improvement. We do have this study here that is suggesting that the efficacy of GPOM may diminish over time. And we don't have good studies that are looking at that holistic care plan of looking at all the components of gastroparesis care, antiemetics, prokinetics, diet, treating comorbidities, and how those patients with GPOM do. There are some studies looking at the combined approach. Some institutions are doing Enterra, and they're doing a pyloroplasty, a surgical pyloroplasty, at the time of the Enterra placement. We're starting to see some articles come out about that. There is a recent study combining surgical pyloroplasty and gastric electrical stimulation in gastroparesis patients, and that may be superior than doing a pyloroplasty alone in this 2022 study. Here's a study that in 2018 was published about maybe a stepwise approach, and we call this, they called it a tailored approach to gastroparesis. So they took 58 patients, and of those patients, 46 had Enterra placed, and of those 46, 13 of them went on to choose to do a pyloric intervention. In that original group of 58, 10 decided to do a pyloroplasty, and then later, 3 of them went on to place an Enterra. And only 2 patients went on to do a sleeve gastrectomy, which is another topic that we're not going to talk about today. But that was so low that that data wasn't analyzed because there was only 2 patients. So what did we learn from this? They took the 7 central symptoms of gastroparesis: nausea, vomiting, bloating, fullness, those, and they had one scale that said how severe is your symptom. They had another scale that said how frequent is your symptom. So that together was a 14 symptom survey. And the patients who had Enterra alone, 12 of their symptoms improved significantly. Those who had pyloroplasty alone experienced symptom improvement in 4 of those categories. So these patients ended up getting combination therapy, and in total that was 16 patients. And they did show some additional improvement. So that would argue that if we don't have full improvement with one therapy, we could do another. That also argues that you don't have to do one before the other. There's not a prescriptive order of events. You might just think about how that patient is presenting. The way I think about it is sometimes if a patient has really bad postprandial bloating and fullness, I might think about or entertain the idea of pyloric intervention for them. So the authors from this study, they concluded their preference is to use Enterra alone first, and that they consider doing a pyloroplasty if the person didn't get full improvement from the 2. So these symptoms were measured after the first operation to post-operatively for the second one. So the idea here is that they didn't have full improvement with their first therapy, but they had further improvement when they combined therapies. So it's an argument for thinking about doing that next step therapy if your patient doesn't have full improvement. So in our patients who have really severe presentations, and that's essentially what we're talking about today with this group of patients that, you've tried diet, you've tried medications, it is important to go back to that original algorithm. And when we made that algorithm, we made arrows going in both directions because we have to go back to diet, we have to go back to medications, we have to think about these advanced therapies, combining advanced therapies. Of course, sometimes we need to do supplemental nutrition and hydration in this patient population. For patients who are extremely severely ill and you can't get them better with anything, you could consider gastrectomy. I have never sent a patient for gastrectomy ever in my entire career, but I have had some patients who have severe morbid obesity choose to do a gastric bypass. My numbers are so low I can't give you outcome data on that, but potentially that could improve symptoms. But if they have vagus nerve disease, they may not get full improvement from a bypass surgery.